So again, thank you to everyone for giving me the opportunity to present here today. And I know that a lot of what I'm going to go through may not be completely apropos to your own practices, but there are still occasions where, you know what, regenerative therapies just don't work, and sometimes you do have to send your patients to surgeons. Now we've got a couple in the audience as well. So today I'm going to really be talking about the use of biologics for fracture healing and spinal fusion. And I know that all you're wondering, why do I have to sit here on a Saturday morning and listen to this guy? I want to hear about, stem cells and things like that. But, just to kind of share, my resume, if you read the Washington Post, sometimes I am featured in the Washington Post for issues related to back pain. Or perhaps you, on the internet a little bit more, if you're on Becker Spine Reviews, sometimes they ask me to comment on various spinal issues. Or the Huffington Post, I'm kind of their official spine surgeon of the Huffington Post as well. And for any parents out there, if you happen to have back pain after giving birth, I can certainly give you comments, ways to treat your back pain as well. And actually, if you ever heard of the term tech neck, I helped popularize that term in Vogue magazine many, many years ago. So I'm just a wellspring of very, very practical information. If you're looking for a new bed, I can help you pick out your mattress. And I'm not quite sure how I became kind of the expert at this, but if you're having a lot of back pain from the size of your breasts, I can give you a lot of information about that as well. So again, hopefully this will be enough to kind of keep you interested for the next 30 minutes or so. So again, we've already talked a lot about biologics, and I think it's really an exciting time in the field of orthopedics and spine. There's a lot of different applications for biologics. We've already talked about kind of regenerative therapies, but certainly bone formation, spinal cord injury. There's a lot of different materials we can use, but there's also a lot of issues that we have to discuss, whether it's efficacy, safety, cost, the regulatory issues related to biologics. And again, certainly the science behind many of these regenerative therapies has only grown. The literature certainly supports utility of these strategies. And again, Dr. Chabot already talked about how the lay press has gotten a hold of this as well. You're seeing famous athletes adopting these therapies, politicians. Unfortunately, you're also seeing reality TV stars also adopting a lot of these therapies. But in some cases, sometimes these regenerative therapies aren't enough, and we do have to rely on conventional orthopedic and spine procedures. And many of these procedures are dependent upon the formation of bone, whether it's fixing a fracture, filling a bony defect, joint fusions, or certainly spinal arthrodesis as well. So again, I think as surgeons, a lot of times we're more concerned, what plate, what screw should we use? Or maybe we're thinking, should we go from the front? Should we go from the back? But at the end of the day, bone formation is a biological process that's really predicated on three critical factors: osteogenic cells, osteoinductive growth factors, and an osteoconductive matrix that can support bone formation, whether it's a fracture or the spine. So again, what you need are these stem cells that respond to osteoinductive growth factors so that they can develop into bone-forming cells and ultimately lay down bone on these osteoconductive scaffolds. So despite our advance in technology, there are still a number of different factors that can compromise bone formation. These may be systemic. Does the patient smoke? Does the patient have osteoporosis? It can be local. Is there instability? Is there poor soft tissue coverage? It can also be technical. Are we trying to fuse 10 levels of the spine or 2 levels? Is there implant failure? So despite our best efforts, the problem of non-union still is a clinical problem. And we know that non-union contributes to poor clinical outcomes. The patients are going to have increased pain, recurrent symptoms, compromised function, and it follows that these patients are also going to have higher costs as well. They're going to need ongoing treatments, including revision surgery. So here's kind of an example, a real-world example. So this is actually a patient of mine. She had a spinal cord injury, fell out of a wheelchair, broke her ankle. So I don't do a lot of general orthopedics anymore, but I like to think I can still fix an ankle. Everything looks great, very, very happy. Then she comes in about 3 months later. can't feel her leg, so she's been walking on it, develops kind of this Charcot joint, completely destroys her joint. So at that point, I have to send her to one of my trauma colleagues. They have to revise the fracture. Ultimately, she's healed, but at what cost to her and to society? Now, this is one of my own patients. So this is a patient who has some subtle instability at L4, L5, has developed facet joint cysts resulting in stenosis, fails non-operative treatment. So we end up doing a posterior interbody fusion. Patient does great for about the first 2 to 3 months, and she comes in with searing pain going down her leg. And you can see from these imaging studies that unfortunately she didn't fuse, the cage is now in the canal, putting pressure on that nerve root. Now she's got symptoms going down the leg. So obviously this is something that requires more surgery. So we go through the back, take out the cage, go through the front, do an anterior interbody fusion, go back in, put in new screws. So again, ultimately we were able to get her to fuse, but it did take a lot of surgeries to do so. So this unfortunately is an example of a patient that just walks into the emergency room, and basically her chief complaint was that she had difficulty swallowing. So as it happened, one of the surgeons in the area had done a corpectomy with an uninstrumented fusion. Just put a piece of dead allograft in the bone, so this dislodges, erodes into the airway. ENT puts a scope down there, sees this big piece of fibrillar allograft sticking, in the airway. So what do we have to do? We have to go in through the front, reconstruct the airway, going through the back. So again, another example of how ultimately we were able to address this issue, but my feeling is that the best way to do it is to do it right the first time. So in order to reduce the risk of non-union, for all of these procedures, we generally will use some type of graft material. And the fusion process is going to be influenced by the characteristics of that graft, including the cellular aspects, the biochemical and mechanical properties of the material. So what makes up an ideal bone graft material for fusion? Again, you need the 3 things necessary for bone formation: the osteogenic cells, the osteoinductive growth factors, a supportive osteoconductive matrix, and you need this material to provide sufficient support for the type of surgery performing. But we also want fusion rates to be equal to autograft. We don't want any donor site morbidity, minimal risk of disease transmission. We like it to be available in unlimited supplies. We want it to be inexpensive, easy to store and use. So obviously there's a lot of boxes that need to be checked. I think many of us would still agree that the patient's own bone is still the gold standard for spinal fusion, simply because it's the only material that contains the 3 things needed for bone formation: osteogenic cells, osteoinductive growth factors, and this osteoconductive scaffold. And it's also available either for cortical or cancellous grafts, depending upon your procedure. Unfortunately, with autograft, there are a lot of disadvantages. It's only available in limited quantities. That's an issue if you're working with children who have these scoliotic reconstructions, multi-level procedures, revision surgeries, or mini-invasive procedures. If you're doing a procedure for a very, very small incision, you might not be able to procure any autograft. There's also significant donor site morbidity. A lot of times it requires a second incision, increased operative time, blood loss. There's also a number of complications that can occur when you procure autograft. Probably most commonly, it's going to be intractable pain. A lot of times patients will complain more of pain from the autograft site than they will from the actual surgical site. There's also more serious complications as well, including fracture or neurovascular injury. So again, there are systems that are available to be able to harvest autograft through a very minimally invasive approach. And here's kind of an example of a marrow solution autograft system that is commercially available. We'll actually have access to in the lab. So this allows you to harvest cancellous autograft in conjunction with bone marrow aspirate through a percutaneous approach. So literally you're doing this through a little incision directly over the crest. You're able to extract this cancellous bone with an 8-gauge trephine needle. So again, we'll go over this in the lab, but you have this needle that you advance directly into the iliac crest. You basically sound the needle to make sure that you know how long your graft is going to be. You take out the canyon, then put this trephine in to kind of extract the bone. And then basically what you do is you remove the needle, and it's got this piece of bone in there that you can take out. So Just to briefly go over, there's a nice animation here. We'll see if this works. So again, this is an example of very, very simple system. You basically have this needle with the trephine in there that allows you to extract this cancellous bone literally through a percutaneous approach. So again, this is ideal for spinal fusion procedures, or really any type of orthopedic procedure that requires bone formation. Yeah?
I've actually, this is a great system.
Yeah, it really is.
It really is, because you're getting live, intact trabecular bone marrow and using it as a graft. In my office, I was the first one in the United States to do this in an outpatient setting for treating hip AVM. So you're actually putting this graft into the AVN lesion and backfill it with bone marrow. What better than to put live bone into a dead bone area? So
Yeah.
This is great.
And again, I think that's a good point, the trabecular bone. You're not just getting, the aspirate, you're actually getting trabecular bone in here. So again, you're literally doing this through a little poke hole, and what you can do is, you can actually extract these cylinders of bone. And you can actually repeat this multiple times depending on how much bone you have. So once you take out the extraction needle with the bone in it, you use the same kind of sounding rod to take it out, and then rinse, repeat as many of these dowels as you need. So in order to reduce the risk of complications, reduce the morbidity associated with harvesting autograft, a number of different materials have been developed as alternatives to autograft to promote bone growth. And these may be broadly classified into either extenders, which are combined with autograft, or actual substitutes that may be efficacious even without autograft. As you might imagine, the efficacy of each of these materials is dependent upon the clinical application for which it's being used. So the best material for an anterior cervical fusion may be different than the best graft material for, say, a tibial non-union. And it also depends on your procedure. Again, the best option for a primary fusion may be different than for a tibial non-union. So again, this slide lists a number of different materials that are available to promote bone formation. And usually when there's this many choices, it means that there's not one good solution. So there's a veritable buffet of biologics that we can use for bone formation, and sometimes it can be a little bit confusing to figure out which is the best one for your patient and procedure. And put it frankly, it's very difficult to just expect to take one material, put it into the spine or a long bone, and expect bone formation to occur. So that's a lot to ask of a particular biologic. So when I think about biologics for spinal fusion or orthopedic procedures, I really focus on a concept known as osteogenic capacity, which is the ability of that patient to form bone following a fusion procedure. And again, this is based upon patient factors, procedural factors, as well as the type of disease you're treating. So again, we know there's a lot of different medical comorbidities that can affect bone formation, whether it's smoking, osteoporosis, malnutrition. We already talked about how apparently there's no obese people in Connecticut. While we like to think everyone looks like this, sometimes you do end up with patients that look like this. And you can imagine that getting a solid fusion in a patient like this could be very challenging. As with any type of procedure, also psychosocial issues can affect the success of a procedure, whether it's depression, anxiety, workers' compensation, where they just don't want to go back to work. Again, all of these can affect the success of your procedure, whether it's a fusion or an injection. Similarly, you look at the disease. The ability to fix this is going to be a lot different than this. It's going to be a lot different than this. Or if you're trying to fuse the spine, your chance of getting a successful fusion for this is a lot different than it is for this, or something like this. So again, these are all factors that can affect your bone formation, which could, again, change the way you think about bone graft materials. And finally, we look at the procedure itself. What kind of instrumentation are we using? Do we have inner body support for the fusion? Is this open MIS? And again, I think the bone graft material is a very important consideration as well. So I think it is important to match your graft to the particular patient. So if you have a patient on the far right, very healthy, that graft may not be as important as it would be for say someone on the far left who has a lot of medical comorbidities, who's less likely to form bone. And in a case like that, you might be more dependent upon your graft material. Similarly, kind of depends upon your procedure. If you're doing a single level fusion in someone healthy as opposed to a multi-level revision adult deformity surgery, you may have to rely on your bone graft more in order to obtain a solid fusion. In this day and age of limited healthcare resources, obviously there are economic issues as well. As the use of these bone graft materials increase, again, these bone graft materials can be thousands of dollars. So you multiply that by how many cases are being done across the United States, you can imagine why people are pushing back on a lot of these biologics. And really, we don't have a lot of data confirming what's cost effective in terms of the application of bone grafts for these procedures. So there are a number of cell-based strategies that we can use when talking about bone graft substitutes for bone formation. That includes bone marrow aspirate as well as stem cells. So again, we had some very, very smart people talking about stem cells. I don't want to go into too much detail, but these stem cells, as you know, are basically undifferentiated cells, which do, at least in theory, have the capacity to develop into various tissues, depending upon the signals in the local environment. They also have the ability to undergo self-renewal. So there's a lot of different types of stem cells. We already kind of talked about how the embryonic stem cells may be a bit very bulletin right now. And really when we talk about stem cells for these types of orthopedic spine procedures, we're looking at mesenchymal stem cells, or medicinal signaling cells. So again, you're going to hear me talk about MSCs. Again, it's medicinal signaling cells now. So these MSCs are basically adult stem cells which do have a capacity to self-renew, and they're multipotent, meaning that they can, at least theoretically, form into any number of mesodermal tissues. And as a spine surgeon, obviously I'm most concerned about bone. Now, compared to embryonic stem cells, these MSCs have less potential for differentiation, so their fate is really dependent upon different factors that are present in the local environment that help steer them down a certain lineage. And there are these mesenchymal stem cells can be obtained from a variety of tissues, but again, most frequently, we will procure them from bone marrow. So when you talk about bone formation of these MSCs, there is potential for them to differentiate into bone, but also other tissues as well, depending upon the local environment. The surrounding cells, biomechanical forces, other factors that can diffuse in the local environment. So the real challenge when you talk about stem cells is that, again, we want to make sure that they turn into bone and not these other tissues, at least when we talk about things like spinal fusion. So we already talked briefly about bone marrow aspiration, and this is a source of both osteogenic cells as well as osteoinductive growth factors. This is autologous tissue, the patient's own tissue, so there's no risk of immunogenicity, there's minimal risk of infection, and again, you'll see you can really obtain bone marrow aspirate very, very easily with just a needle. Because it's a liquid, at least for spinal fusion, you generally need to combine it with some sort of carrier to form a composite graft. So, as is it Chabot talked about, bone marrow aspirate technique matters because bone marrow aspirate really only exhibits moderate osteogenic potential. You can imagine when you're pulling up 10 C's of fluid, the majority of that's going to be red blood cells. It's not going to be stem cells. And it also depends on the age of the patient. So the younger you are, more likely you're going to have more of these MSCs. So technique does matter. The concentration of these cells is going to be affected by the harvesting technique. If you don't do it correctly, you're going to really, really dilute the stem cells and decrease the osteogenic potential. So if you have kind of a conventional needle, really the technique is you put it in one area of the iliac crest, for instance, you draw back 1 to 2 cc's, then you have to draw back and then insert it to another area of bone marrow. However, we now have other systems that can be used to optimize the procurement of osteogenic cells. Now, one option obviously is to centrifuge, like we talked about. But again, the problem is if you use a conventional needle where the hole is really at the end of the needle, what happens, you get 1 to 2 cc's of bone marrow, but then what happens, that space fills up with blood, and then when you pull back again, you're gonna get kind of the tissue of least resistance. So as you pull back more, basically all you're getting is gonna be red blood cells. So of that 10 cc's, it's really, really gonna be diluted with peripheral blood. So again, Marrow Solutions has this bone marrow aspirate system. And I don't know, Dr. Twain, if you use this as well, but this also allows
Marrow Solution device?
Yeah.
Yeah, I've actually been using it since they first introduced it, and it's the only way to go, hands down.
Exactly
I
right.
actually published a white paper on it showing superior CFU counts.
Yeah, and it makes perfect sense if you look at the design. So again, this system allows you to aspirate bone marrow in a measured and controlled fashion over a large region with a single stick. So again, unlike most needles where the opening is really at the end, this is a closed-end needle, and it's basically fenestrated where you have a bunch of windows on the side of the needle, which limits the amount of blood that you're pulling up. This system is available in a variety of lengths depending upon where you want to harvest bone marrow aspirate, depending on the procedure that you're performing. So again, basically you have this single needle, you're inserting it into the iliac crest, and then what you do is you take out the sharp stylet and you put in a syringe just to kind of confirm that you're in the iliac crest. And then what you do is you put in the blunt stylet and you advance the handle down, and again, this will be in the lab, so this outer handle is right up against the skin. And then what you'll do is you'll drop 1 to 2 cc's, and then you'll turn the handle, which basically kind of lifts the needle upwards, and then you draw another 1 to 2 cc's, and so what you're getting is a more concentrated bone marrow aspirate. So again, if you think about the previous figures that we looked at, again, this needle is closed-ended. All of the fenestrations are on the side. So again, you drop the bone marrow aspirate, 1 to 2 cc's, then as you turn the handle, this needle is coming more superficially, so you're able to draw kind of bone marrow aspirate from a new area of the iliac crest. So again, you're getting a much, much higher concentration of MSCs within your aspirate. So again, this is just kind of a brief video if it'll come up. So this is again through a single incision. It's not even really an incision, it's really kind of a poke hole. So you kind of start off with a blunt stylet, basically to get yourself into the iliac crest. So again, what you want to make sure is that with this bone marrow aspirate, that you really maximize the amount of stems that you're getting and not getting the peripheral blood. So again, you're basically, again, you don't really even need to make a incision. You're inserting this needle into the iliac crest, and you have initially this sharp stylet that you insert into the iliac crest. Then what you do, once you think you're inside the iliac crest, you take out the sharp stylet, and then again, just to confirm that you're in the right place, you put a syringe, a lure lock on, and just briefly draw back a little bit, just to make sure that you are actually in the correct plane. Then you put the blunt stylet in, and then what you're going to do is insert this needle to the proper depth.
By the way, that first 1 to 2 cc's of marrow that you pull as soon as you go through the cortex, liquid gold.
Yeah.
Loaded with tons of regenerative cells.
So again, then you kind of turn the handle, and then again, what is novel about this needle is that the fenestrations are on the sides. You're actually not pulling out from the bottom, you're pulling out from the sides. So then you turn the handle, and what happens, the needle is going more superficially, so you're getting to that virgin bone marrow and getting more bone marrow aspirate. So the aliquots you're getting is not going to be actual peripheral blood. It's going to be again, just kind of like that initial aspirate of bone marrow. So again, the goal of this is to avoid diluting your osteogenic stem cells with peripheral blood. So you can take up to 10 cc's of good quality bone marrow through literally a single needle stick. Now, in addition to bone marrow aspirate, there are so-called stem cell products for spinal fusion. These are MSCs harvested from allograft bone, which at least in theory have the potential to differentiate into osteoblasts. These are generally combined with a carrier matrix as well. So there's a number of different stem cell products for fusion available on the market. Again, all of these are harvested from allograft bone. They all have to be processed in some way in order to preserve these cells. And as with any type of allograft tissue, there is strict screening of donors. They review the medical records, they do laboratory testing, obviously to decrease the risk of any type of infectious agent. So the processing of these tissues is critical because, again, you're trying to maintain cell viability. So generally, they'll process this bone as quickly as possible. There has to be kind of controlled rate of freezing, which is going to be time and temperature dependent. Then these cells are suspended in this cryopreservation solution, and all of these products need to be stored at sub-zero temperatures. All of these products do undergo testing in order to ensure their sterility, cell count, cell viability, their osteogenic potential, and because it's live tissue, there is going to be an expiration date on these products. So again, these have to be stored at sub-zero temperature. Once they're ready to be used, you thaw it, you decant out that solution, and you reconstitute it in sterile normal saline. Then you implant it into the site where you want the bone to form. Now, technique again is important because if you don't do this correctly, this can actually lead to increased cell apoptosis. So again, when you're looking at things like allograft bone, there's going to be a lot of variability that can affect the efficacy of these products. Again, quality of bone. If someone has osteoporosis, you would expect it not to be as osteogenic as someone who has less osteoporosis. You look at the age of the donor. That can also affect the viability of the tissue as well. Now, I think one of the big hurdles with these products is that these companies don't really share their processing techniques. So we don't really know how they're harvesting the stem cells, how they're getting them to remain viable over time. And so that's a real issue, I think. The type of carrier, how long you can keep these products in the freezer. And then again, a big characteristic is going to be the final concentration of viable stem cells. So again, there's a lot of questions with these types of products, and unfortunately it doesn't take much to bring these allograft products to market because they're so-called minimally manipulated tissues. So you don't necessarily need the same kind of data that you would need for, say, a synthetic material. But obviously there's questions about the osteogenic potential. How do we make sure that these stem cells are actually still viable? And unfortunately, there's not a lot of high-quality clinical investigations to really kind of support their efficacy. I think in general, because it's allograft bone, because of the way they're processed, generally these products are going to be quote-unquote safe. But I don't know if you guys have heard, there was actually a stem cell product that gave these people TB, tuberculosis. So, anytime you have allograft tissue, there's always going to be issues with safety. And a lot of these stem cell products have a very high price point, so their cost effectiveness remains a matter of some controversy as well. So, I would say that in the field of spine surgery at least, these stem cell products really haven't caught on too much. So I think in the future, we are going to need better studies, not only clinical, to establish their safety and efficacy, but also economic analyses as well. We need to make sure that they're cost effective before our institutions, before insurance companies will cover it. And I think in the future, you are going to see novel formulations, whether it's improved carriers or composite grafts that combine many different materials. So just like some genius thought about combining peanut butter and chocolate, or how now we have phones that are really phones and computers, I think in the future, it's really going to be a combination of materials. You're going to have these osteoinductive factors combined with an osteoconductive matrix. You're going to have stem cells that can respond to these different factors. And then also, we can't forget about the vascular supply as well, which is critical for bone formation. So in conclusion, I think many of us would believe autograft is still the gold standard for promoting bone formation. There are a number of different graft materials that have been developed as extenders or actually substitutes to promote bone growth. but obviously we're going to need better data to support utilization of these materials in our own practice. So that kind of, how are we doing on time? Are we? Okay.
Really good.
I just have a couple of slides just to kind of talk about my journey from very naive practitioner to someone who's seen a little bit more over the years. And certainly my practices have changed from doing surgeries like this to now doing less invasive surgeries, to using conventional technologies, and now having newer robotics and navigation, or using autograft and now having other tools as well. And I think as practitioners, we're all bombarded with different strategies, different technologies. And I think it's really important to think about how we decide what we want to do and what we don't want to do. And it's obviously throughout history we've seen medicine evolve, whether it's antibiotics, x-rays, general anesthesia. Certainly the introduction of internal fixation has changed spine and orthopedics. I think if you had had a cholecystectomy 40 years ago, you'd probably be looking at something like this. But now the standard of care is to do things in a different and, I think, better fashion. And certainly in orthopedics and spine, it's a very exciting time in terms of biologics, different technologies. Now we're all talking about artificial intelligence. I don't know if you guys have seen this in your practices, but now we have a system at Yale where literally you just speak to your patient in your phone, and this program somehow creates this note that just gets inserted into the medical record. So you're not actually typing anything, you're not dictating it, it's just listening to you and creating the note, which is kind of cool, but maybe also a little bit scary. So again, I think all this technology has to be used in the right way. So obviously, I think all of us agree new technology in general has been a good thing for medicine. You can decrease optic morbidity. Now, for instance, we've got ways to improve the way in which we put in pedicle screws. It can improve operative metrics. There's less blood loss, shorter OR times. Maybe patients don't have to be in the hospital as much. Maybe they don't need as many resources after discharge. And hopefully, a lot of these technologies will translate into better clinical outcomes. Maybe you can get a better fusion rate. And then the question of cost, I think that's an issue as well. Now, many of these new technologies do have an increased upfront cost, whether it's a capital expenditure or maybe the products are more expensive. Certainly in terms of surgery, there's going to be a learning curve, so the OR time is going to be longer. But there's certainly potential for savings. Patients don't have to be in the hospital as long. Maybe they go home the same day. There's less utilization of resources. They don't need rehab afterwards. And again, there's the possibility to avoid certain adverse events. So, when you talk to your institution, a lot of times they're focusing on the tip of the iceberg. Well, that's going to cost us so much more per case. I'm just not going to improve it. But they're missing kind of the point of this new technology, that there are a lot of other advantages, whether it's avoiding the fusion with regenerative therapies, or maybe having a robot to increase the accuracy of screw placement. So there's a lot of potential advantages, and at the end of the day, can you really put a price on how to avoid a complication like this, where you have a screw that's actually probably spearing the spinal cord? So again, I think this is a battle that we're always grappling with, with our institutions. Now, certainly there are disadvantages to new technology for sure. Again, there's a steep learning curve. I think the reason you guys are here is that there's a lot of things you didn't learn during residency or fellowship, which is why you're trying to educate yourselves now. Certainly there's the potential for new complications. For instance, a lot of these new technologies are dependent upon fluoroscopy or radiation. So while this may be me in 2024, what happens in 20 years when I've been subjected to all this radiation? And I think, surgeons in particular, I'm sure that many of you are also cognizant about fluoroscopy, how much radiation you get. How many of you are using lead goggles or, leaded gloves? You're good. I think most people don't. I don't. Yeah. So it's crazy. I think you're in the minority, though. I don't think everyone would use that. And again, you hear about these surgeons dying of these rare cancers. I think there's definitely something to it. Now, again, another potential disadvantage of new technology is that you may be bringing in a new range of complications, and maybe you're just not really accomplishing your goal. And if that's the case, why do the procedure? So again, I will admit this is one of my own cases where I do some spinal endoscopy. And this is a patient who had a little bit of radiculopathy from some crown stenosis on the left side. So this is the preoperative MRI, and this is the postoperative MRI. And maybe the foramen's a little bit more open, but again, this is a case where the technology, maybe it was technology for a reason. I really wasn't able to accomplish the goals, which was to decompress the nerve. So regardless, I think all of us are enthusiastic about new technology. Certainly patients are as well. I mean, I'm sure you have patients looking for these new regenerative therapies. You know, again, industry is very supportive of this, but sometimes what ends up determining what we can and can't do are going to be third-party payers. So there are a number of barriers that we've all encountered in terms of adopting new technology, whether it's economic, whether it's just kind of developing new skills. They say that 80% of what you do in practice is what you learn during residency and fellowship. So it's not easy to pick up new techniques, new technologies. It does necessitate additional training, which is why you're here on a Saturday morning. And again, we don't want to reinvent the wheel. We've done things the same way, we know how to do it, we're good at it. Why would we want to increase our operative times? Why would we want to introduce the risk of more complications? So here's an example. This is a study actually looking at the learning curve for robotic spine surgery. And they looked at a number of different surgeons and found that there's about 25 cases before you become really facile with robotics. I don't know if you guys do robotics or not. I thought it was a little bit less than 25, but still, again, we're all comfortable doing spinal fusions. Now you're changing the way we do it. Who knows if that's the right thing or not? And this kind of raises maybe ethical implications as well. Do you want to be one of those first 25 cases of your surgeon where they're kind of learning how to use a robot? A lot of times this new technology, as Dr. Trotman said, there's not a lot of good data supporting it. So you don't want to think that you're subjecting your patients to human experimentation, but a lot of times we do kind of learn on our own patients. So again, that's why I think that literature, data is very, very important. And obviously we want to focus on higher quality data, level 1 prospective randomized controlled trials. But as Dr. Trotman said, they're very, very expensive. In spine, it takes millions of dollars to do a study like that. So the question is, how much evidence is enough? I mean, is it enough just to have your buddy tell you that he's tried this and he really likes it? Because again, while we might think that a lot of this new technology is a blessing, we certainly don't want to be putting our patients at risk either. So kind of when I think about what to do, what not to do, number one, I think, does it fit into my practice? Does it make intuitive sense to use three-dimensional intraoperative navigation? Yeah, I think it probably does. Does it make sense to, if you guys remember, putting a butt screw up to fuse L5S1? Probably doesn't make sense. Does it fill an unmet need? Is this something where in my practice I really need something to make it better, or is it something that I'm comfortable doing myself? I think an important consideration I think about as well is there's sufficient evidence. I don't want just a white paper telling me that this is safe and effective. I would like a little bit more data to show that it's safe, that it's effective, that it's cost effective, before I start thinking about using it with my own patients. And ultimately, another question is, will I even have access to it? If Yale doesn't approve this machine, if the insurance company doesn't allow this device to be used, again, I'm not ever going to have access to it. So, I think these are important things. Again, I think the fact that you were all here to learn these regenerative techniques really kind of shows that you're on the tip of the spear, because I think a lot of medicine is going towards regenerative medicine. So I applaud all of you for making the effort to come. But again, I think we should all have kind of a critical idea about what we use and what we don't use. And I guess what I would like to do, Dr. Biskup, I mean, not that you're old, but you've got decades of experience, you've seen it all. Like, kind of what's been your philosophy, when someone comes to new technology in terms of what to use and what not to use, in your own practice?
I'm actually going to cover it.
Okay, good. Because, again, I'm sure that all of you are kind of inundated with new technologies. Every company wants your business. And I think it is a challenge to really figure out what we should use and what we shouldn't use. And so I think it's important moving forward that we all tend to be very critical about what we adopt into our own practice and how we treat our own patients. All right, and that's it. Thank you so much.